Welcome, everybody. I'm Jeff Borenstein, and I have the privilege of serving as the president and CEO of the Brain and Behavior Research Foundation. And I'm looking forward to our conversation this evening, in the afternoon on the West Coast, about incorporating universal screening and school-based mental health initiatives in the classroom. I'm speaking with one of the top experts in the field, Dr. John Constantino. Dr. Constantino is the Liz and Frank Blake Chair of Children's Behavioral and Mental Health and inaugural System Chief of Behavioral and Mental Health at Children's Healthcare of Atlanta. He's a professor of pediatric psychiatry and behavioral sciences and genetics at the Emory University School of Medicine, where he also serves as vice chair of the Department of Pediatrics. Dr. Constantino is also the 2024 winner of the BBRF Ruane Prize, which is given for outstanding achievement in child and adolescent research. We're going to focus our conversation for teachers, school counselors, other education professionals, as well as parents and family members. So with that, I'm going to jump right in. John, thank you so much for joining us today.
Thank you so much, Jeff. It's great to be here.
Thank you. And I want to start just by you sort of laying the groundwork about what's the current status of screening in schools.
It's a great question. A recent survey of over 1,000 school principals published in one of our major journals asked a couple of questions of leaders of schools. One was whether or not their districts had adopted a screening policy for mental health conditions of students. And 70% of the time in this representative, sample of school districts, the answer was no. There was no real policy about mental health screening. Another finding from that particular effort was that 40% of the time, the principals said that when a child was identified as having a mental health condition, it was very difficult to ensure that they would receive appropriate mental health services. And so you can imagine this kind of tension about whether or not to screen when identifying, a child with a mental health need in a school could result in a lot of difficulty with even, acquiring the services that then one knows that they need.
So you bring up two important issues. One is the screening, and then what do you do after you do the screening? So let's start with, where are we in terms of screening? What types of tools are available? You've been at the forefront of this. Tell us about that.
Yeah. Some of the most important things to screen for in school are what would be described as the internalizing symptoms, the things that would be hidden and that wouldn't declare themselves. So, for example, disruptive or externalizing behavior, you don't really necessarily need to screen for that because it's pretty evident, when it's happening. But when children are internally upset, depressed, anxious, even, or those that are kind of going down a road of addiction or substance use disorder, kind of symptoms, then screening is really very important. So in one of our larger separate recent study of over 12,000 students in Pennsylvania, in a randomized controlled trial, the research showed that if you screen systematically, you up the identification of depressive syndromes in youth by 6 times by screening, a six-fold increase, and you double the likelihood that you're going to successfully initiate a referral and treatment process for those youth. So it's very appealing to think about the possibility of identifying these sort of hidden cases that would not otherwise come to light in a school setting where children are spending, most of their time, and that translates into the opportunity to, deliver care and treatment that we know works.
And we know that early diagnosis and intervention makes a big difference rather than waiting until it gets worse to deal with it earlier on. It really makes a difference for the child.
Absolutely. I mean, but the other aspect of it is that sometimes it's not even early. It's children have been harboring these, symptoms can happen for a very long time. In the United States, um, it's years after the onset of an actual diagnosis that most children are either diagnosed or treated, if at all. And so I think the point of it is earlier is definitely always better, but people should understand that some of these symptoms that would be identified in clinical syndromes that are identified in school children can be things that have been smoldering for quite a long time, and any opportunity to get a child into treatment, and the screeners are very good at identifying who has mild symptomatology versus very significant symptoms that would warrant clinical treatment, or even in the at the far end, what are real true emergencies for safety of those children and the people around them.
So I want to ask you, because we have a good number of teachers, other educators, leaders in schools are watching right now. What what's available to them in the here and now? What can they do if they wanted to begin a process of having screening in their schools?
Sure. So the first thing is that in making those kinds of decisions, usually schools have to or a district has to make a decision whether they want to individually acquire consent from parents for every time that they screen a child, or the taking the opposite approach, which is rather than opting in, that what's referred to as an opt-out approach. In other words, that if a parent says, please don't screen my child, then they won't be screened. But otherwise, the standard for the school is going to be to screen children in school. And there's lots of instances around, the country where opt-out strategies have been very successful and acceptable. And generally, those have to be approved at the level of the superintendent or even, the county legislature, that this is going to be how we're going to manage risk of mental health conditions in youth. So that's the first layer. Second layer is picking screeners, and there are some really great brief standardized screeners that young people can fill out on their own, can do electronically or on paper, that have a great deal of validity in identifying symptomatology. And like I mentioned before, so many times people are, thinking, well, is a child going to, respond truthfully, or, what good is it to ask them directly? And decades of literature indicate that if you just ask in a way that is, private, and that is in a kind of a, screening kind of framework like this, that they will very commonly tell the truth of their symptoms and identify, as I said before, much more likely to identify, those kinds of symptoms. So the screeners are available. They're brief. They're inexpensive. Many of them are public access. And then there also have been identified a number of really spectacular electronic platforms that make all of this so much easier, because it's time intensive to acquire a measure and score a measure and then respond to a measure. There are organizations around the country, and I think this is particularly relevant particularly in rural school systems and school districts, where you really need a platform that makes all of this seamless, and uh, um, the ability to obtain the measure, score the measure, cue a school counselor, cue a parent when a clinical condition is identified, and then even to send out to parents and to the school opportunities for resources. And so we have colleagues, for example, who an example is our colleagues at the Rural Behavioral Health Institute in Montana, that have utilized electronic platforms like we use in the electronic health record to make all of this kind of activity seamless, to screen whole populations of children in school. And there are other examples in Michigan and other states where this has been done to great advantage to make it a seamless electronic kind of activity.
We'll put on our website after this is complete, because we'll also have we're taping this, some of these resources
Yeah,
that you're mentioning, so people could then get that from the
great.
website, which would be
Sure.
very helpful. The so the a school can, in the way you describe, make the decision to do the screening, and then we get to the question of what do they do next? What
Right.
when they have so speak a little bit about how resources can be developed so that children who are screened positive and may need an evaluation, a more careful evaluation, and maybe treatment are able to get that.
Absolutely. Well, the first thing is to think about when there is any kind of a positive result, that there are always risks with that. So risks that would stigmatize a child or that would otherwise result in an unfulfilled promise of, help available for what that child might be endorsing on a self-report, screener that assumes that they would get help for the things that they're reporting. And to not have a strategy on the back end could leave a child feeling, worse after doing something like that, after divulging, that kind of information in a screening instrument. So none of that is to be taken lightly, but the opportunities to uh, use evidence-based approaches to the response to positive screens is really readily available to schools and communities. So generally, schools like to take a tiered approach. So if you think about the kinds of interventions or levels of symptoms for interventions that would be more in the realm of, there are some early warning signs, and let's, take some positive approaches and support this student in a, a more specified way and an intentional way in the school environment. And that is commonly, referred to as the initial tier of intervention, and that might be universally available to kids who are having mild to, minor kind of symptomatology. But as the symptoms that are identified go up in terms of clinical relevance, now you start to think about targeted pathways for getting them to clinical care. Sometimes that can happen within the school. Sometimes that can happen by parents uh, being alerted to those kind of clinical levels of symptoms and being offered the opportunity to either let's take this to the pediatrician, or here are some resources in the community for help for your child that you can, enact. Or, again, in schools that have develop their own school-based mental health services, to make the option for some of those interventions to happen even within the school day. Because oftentimes parents struggle with, okay, I have to take my child out of school. I have to get, go outside of work to, able to, enact a strategy for responding to a clinical need. If my child has screened positive for depression or for anxiety or for, an early mental health condition. And so the ability to actually deliver the initial stages of that within the school is often ideal. And schools are developing methods for their students to be delivered health and mental health services within the school under the aegis of their medical insurance programs, or as a function of, subsidized programs that allow children to stay in place and receive the earliest uh, steps in treatment through the school. Now, it is also true that under certain circumstances, a screener can tell you that there's a likely clinical condition. And as soon as you explore that clinical condition by a clinical appointment, that the next thing that happens is that it turns out to be something that might be even more severe than a school is equipped to handle, or a parent is equipped or is familiar with handling. And so I think the other thing for schools to do is to make sure that in establishing a mental health screening and response program, and whether some of it is done within the school or whether a lot of it is brought to the parents to, leverage their role as their children's guardians to manage the next steps, that when things are really very difficult, or that there's evidence that there is a crisis or a very complicated mental health condition, then that is where the health system needs to do its part and back the schools up and be readily available to the schools. And that can be in the form of, emergency, services within the emergency departments of the surrounding health systems and hospitals surrounding a school or a school district. But it can also be around, timely appointments for kids that really need, the health system to step in for higher level clinical intervention.
I want to ask you a question that I think parents would be concerned about and how to address it, which is the issue of privacy. And these are matters that who's going to know about this? Does it
Right.
go on the quote unquote permanent record, etc.? How is that addressed in the context of school screening and then treatment?
Yeah. It's a great question. And Jeff, I mean, I think this is part of the culture of the implementation of screening. Because if parents are left to feel that screening is just going to be a study in frustration, stigmatization, you know, people think about how the typical vicissitudes of adolescent life might be pathologized, or, this is just part of growing up. What's great about the screeners is the screeners are calibrated to levels of difference that children are experiencing that really at least raise a reasonable question that this shouldn't just be thought of as part of growing up. It might be, but at the same time, there's enough risk inherent of a clinical consequence of an untreated, untended mental state of a child that if that when most parents are apprised of that's what the screeners are really designed to do, and in all aspects of a school-based plan to restore a child to being at their best self and to resume their role in their community and their ability to function academically, socially, emotionally, then the premise of screening is really more about a kind of consensus of a community to say, we we would want this for the kids in our community. We would want there to be a pathway if they're really suffering, and we don't know, for there to be a pathway to get that identified and supply and provide help. So I think the culture of screening has to be one, and the community within a school district, and school districts all over the country vary in how parents' perspectives about screening. But if you think about these conditions, parents parents don't have any problem with screening for, other kinds of like medical kind of risk or other kinds of serious health risk usually. There's, lots of discussion today about vaccinations, but at this stage, nobody wants to take a medical risk with a child that is unnecessary to take. And the fact is, in the United States, and really in countries all over the world, I mean, recent studies within schools across different Western countries, Australia, UK, Canada, the United States, 25% of children in schools have at some point a very serious clinical level mental health condition. And those conditions ultimately kill more kids through suicide and bad judgments and the consequences of addiction than the next 10 leading medical causes of death of childhood combined, including the cancers. These are the conditions that kill kids. So I think as we're raising that conversation and respecting the fact that we're not trying to pathologize or stigmatize children, and if we're screening in a responsible way so that the information is kept private at the first pass, between the school counselors who are always looking for the ways to support kids emotionally and parents, and recognizing that parents still have the authority of what's the next move in the context of these kinds of screening and identifications. I think that's the matrix that we really want to try to promote and help create environments within schools where screening is really health promotion. It's really guardrails of making sure that if there's a something that needs a course correction, that we're there to support that child and keep them moving through, the course of their childhood.
It's a very good point. I think it normalizes the fact that children can have psychiatric conditions, whether it be
Right.
depression, anxiety, post-traumatic stress, chemical dependency, any of the above, and that they're treatable with appropriate referrals.
Absolutely.
I want you to speak a little bit about some of the work that you're doing in terms of skill training to
Yeah.
youth in school and what's
Yeah.
going on with that.
Yeah. This is kind of a pet peeve because our field in child mental health has for now more than a decade had a collection of randomized controlled trials, like the most rigorous of studies that show that if you provide a child training in the same principles that are used for the treatment for depression and anxiety, that is, cognitive behavioral therapy as a go-to first-line treatment when a young person or an adult has a depression or an anxiety syndrome. These are the treatments of choice. That if you train young people in the same techniques that we use to get people out of depression and out of clinical anxiety syndromes, you can prevent them by empowering them with those same techniques. And they are so rather than having to get depressed or have an anxiety disorder before you get access to those skills, that they can be trained and they prevent those conditions. Like we know this. So that's true for the skill set for cognitive behavioral therapy, and now even for a more complex but very important branch of our therapeutic, kind of portfolio, which is dialectical behavioral skills. Those can be taught to children in schools, and they are protective factors. They are life mechanisms for staving off these conditions and really steering clear of some of the pathways into despair and hopelessness and all the things that mental health conditions can really have some of their most cruel impact on the life of a person.
How can educators be trained to then teach students these skills?
Right. They're manualized. Like we already have them. Like the manuals are there. It's just a matter of like, do we choose to use these in school? Do we choose to set up the training programs? And we have, in my new home state of Georgia, we have some wonderful school districts who are, leading the charge of implementing these kinds of, curricula within the school. Sometimes it's targeted for kids who are, really, grouped into classes that can be almost like an elective course that's really, relevant to what things that they might be struggling with and that they know that they need to be coping with. And others, there are universal approaches. Um, I think some of the schools where I've seen this be most successful, I'll call out some of our colleagues in Hall County in Georgia, where not only are they teaching these skills, but you're checking your cell phone at the door so that you're not having the negative, influences of, social media, kind of bombarding you during your school day. And every kid in that public school, in that county's district has an ID. And on the back of that ID, for I think the last that they told me, their own statistics was that 98% of the time that there was the name of an adult in that building that was that child's go-to person if they needed a hand, and that child knew who that was and had a hand in selecting that person that was their adult, their go-to adult. So imagine in the school environment that making sure that screening, skills building to prevent these conditions, an environment in which, there is a kind of a protection from deleterious influences and a culture of when you need help, this is your go-to person, and everybody's got one. these are the kinds of packages of culture and the environment that I think create a really great environment for screening, because then screening is just, let's just make sure we don't miss anybody that otherwise needs help.
A very good point. And it normalizes the fact that,
Yeah.
as you said, a significant number of people are going to have these symptoms. So don't hide, don't be shamed, get help. And I
Right.
love the idea of that there's the go-to person in the
Yeah.
building,
Yeah.
because we all have a go-to
We all need
person and we
a
all need one.
right. And it doesn't sound difficult to do, but it has to be intentional to operationalize that and make sure that it happens and make sure that every kid, has one. And that's an intentionality, that I think is very, very admirable.
I want to ask you, where do you see this going in the next 5 to 10 years? If you had your druthers, what would be going on?
I think that schools become those kinds of places. And I want to be clear that I don't think schools should bear the burden of unmet responsibilities of the health system. You know, we hear teachers often, describe the issue that they are left, you know, managing adverse behaviors that are not being treated or not being tended to and could be, and that they even know that there are treatments for these things that if they're left undone, then what happens is those behaviors affect learning and the classroom and everything else. So first, as a health system, representative of the health system, as a physician, I feel that the health system owes the education system the right backup to make sure that the kids who need health system-based mental health care have it, and not to put that on the schools. But the culture in the schools for training, for prevention, for being a first line for screening, for being the place where a child is going to go to a go-to person because that's who they see every day and trust, you know, on average, way more than they're going to trust a consulting psychiatrist or psychologist or mental health professional when that's their person in the building. I think that we can create a culture, like this. And I think some of our great institutions, I'm thinking right now of the Balmer Institute in Oregon, that is trying to develop a way to do this, to support the schools and develop the right personnel as the front line in a way that's feasible, that's getting backed up by, the medical insurance system, because at the end of the day, the identification of a potential catastrophic case of depression is a medical issue. But we have to work together to make sure that we identify it on time and then have the right way to approach a child and family to treat that and support them in the right venue for doing that.
Well said, John. I just want to thank you so much for joining us today and sharing really such important information. And we will put some of these resources up on the website so people can follow up and get that. And so I want to thank you for all that you do and for joining us tonight. And I want to thank everybody in our audience who joined us, especially the teachers and other educational professionals. These are the people who are taking care of our children and who make such a big difference in everybody's lives and care so deeply about our children. So thank you for all that you all do to help the future of society, which is our kids.
Couldn't agree more.
Good. Thank you. With that, I'm going to say once again, thank you, everybody. Thank you, John. And we will, down the road, continue this conversation. Take care,
Great.
everybody.
Thanks, everyone.
Bye bye.